Hey everyone, it's Ike Ahmed from the University of Toronto, University of Utah. My topic here is clear lens extraction for angle closure glaucoma. Interesting topic. We've seen more evidence generated recently, but there still remains many questions around the world about the utility of removing the lens, primarily for angle closure glaucoma. These are my disclosures. Let's start off with a case. This is a 52-year-old with pressures of 30 and 31 on 5 classes of medication. Gonioscopy showed grade 0 angles with 360 degrees PAS. Patient has no cataract and has had no previous procedures or lasers. One can see that there is optic nerve and RNFL loss, some subtle visual field changes in the left eye, minimal in the right eye. And the question is for this patient, what to do? Well, we know angle closure glaucoma is a worldwide issue. There's a larger risk of blindness compared to open angle glaucoma. And most patients with angle closure glaucoma present in a chronic form. Often they can be missed in the office and there can be wide fluctuations in pressure, and chronic appositional closure can lead to more permanent synechia formation. This can lead to irreversible trabecular meshwork dysfunction if left untreated. There's certainly some evidence in the past that long-term efficacy of laser iridotomy is not great, and the most commonly surgical glaucoma procedure done in the world, Trabeculectomy, of course, has its own inherent complications, which are only increased in patients with angle closure. Let's just start off, of course, talking about the WHO classification for primary angle closure. PACS patients, primary angle closure suspects, patients who have iridocorneal apposition. I like to say that's basically grade 0. You cannot see the iris, and you cannot see the trabecular meshwork with the iris covering the TM for at least 180 degrees. Primary angle closure is the same, but with raised IOP or PAS formation, synechia formation, and PACG are the same above with disc or visual field changes. So when we talk about primary angle closure, let's make sure we differentiate acute versus chronic, whether the patient is controlled medically or uncontrolled, at least in the office, whether an iridotomy is present or not, whether a cataract is present or not, and whether there is PAS or not. It goes without saying that the critical point of examination in differentiating this type of glaucoma is gonioscopy, and this can help elucidate what mechanisms of angle closure are present. And as I will speak about, I think understanding mechanisms are very important to understand what the best treatment is, specifically with opening the angle. Now, there are different ways to identify the angle and structures. Of course, gonioscopy is the gold standard. We are using imaging much more, particularly anterior segment OCT. And this picture nicely shows some of the structures that can be visualized, including the bump, the angle which forms the corneoscleral indentation, Schwabe's line, the bell lamina around the canal, which then forms into the trabecular meshwork, and the ciliary muscle border. When we think about different mechanisms, we can think about different ways the angle can be closed. Pupil block, of course, is commonly discussed. High lens rise with a big lens rotating the iris forward, and plateau iris with a high peripheral iris insertion. It's important to remember that often more than one mechanism is present, and lens rise, or a big lens relative to the middle segment of the eye, is a common underlying factor. Many treatment modalities have been discussed and debated, particularly discussions of laser iridotomy versus lensectomy versus trabeculectomy for these patients. Now, it's well known that the angle after iridotomy doesn't always open, and it remains occludable in up to 60% of eyes based on gonioscopy or imaging. And the reason for this is the patient may have persistent closure due to other mechanisms, plateau iris, high lens rise, both, or other rare mechanisms of angle closure. Even after iridotomy, many patients require medications and some go on to require further surgery. We can see some examples on imaging pre and post laser iridotomy where there's significant change in the angle after the LPI on the left, while on the right, not so much. And you can look at the imaging, you can tell almost and guess almost. The patient on the left has significant pupil block with iris bombé. On the right, there's really no bombé present and a more plateau configuration. So the lens and angle closure, of course, is a very interesting relationship. Typically these patients with angle closure have a relatively large lens thickness and or anterior position of the lens with a relatively smaller axial length and or smaller anterior chamber depth. And that typically leads to these mechanisms of angle closure. Of course, pupil block is often a function of a high lens rise. Mechanisms of lens-related elevated pressure, as I said, include pupil block, and one can evaluate the elevation of the iris off the lens and the functional pupil block that's present. This is iris Bombay. And also directly rotating the iris forward because of a large lens, rotating the iris forward and causing the angle to close. And this is basically direct anterior iris rotation. Remember, two different mechanisms by which the lens can cause elevated pressure due to angle closure here. We can also see examples of where the lens can also relate to elevated pressure. Here's an example where a high lens rise pulls zonules forward, pulls ciliary body processes anteriorly, and this results in a high iris insertion, a phenomena of plateau iris with peripheral angle crowding and closure. And this can result again in another mechanism of angle closure. So we've spoken about pupil block, we've spoken about high lens rise, and we talked about plateau iris. Different ways imaging can help. Now, the high lens rise also rotates the scleral spur anteriorly, and this reduces the effective filtration area of the trabecular meshwork. In fact, this is a mechanism by which the angle can be open but cause elevated pressure. And this also is a mechanism by which removing the lens can lower the pressure by effectively rotating the spur posteriorly and increasing the effective filtration of the trabecular meshwork. This is why removal of the lens is purported to reduce IOP even in open angle glaucoma. So it's quite interesting to think about different mechanisms by which the lens can cause angle closure or precipitate angle closure chronically, and or cause open angle mechanisms of elevated pressure. So removing the lens is part of the solution in most cases. How? It releases pupil block. It rotates the iris posteriorly. It changes zonular vector forces posteriorly and pulls the ciliary body position more posteriorly. It posteriorizes the scleral spur, effectively increasing the trabecular meshwork filtration area. We can use it to release PAS adjunctively and increase the anterior chamber space. Basically, lensectomy opens the angle. We have some examples, of very extreme examples, of a very large lens pushing the iris forward and removal with a significant deepening of the AC and angle opening. But removing the lens is not just for these large intumescent phacomorphic type pictures. It can be subtle, like this example here where we see a relatively high lens rise with the rotation of the iris forward causing angle closure. Remove of the lens has caused the angle to open. And 360-degree visualization of the angle shows a nice pre- and post-op lensectomy. Now, compared to iridotomy, lens extraction is more effective at anatomically opening the anterior chamber angle more so than iridotomies do. This has been shown on imaging. Now, let's just talk a little bit about your patient presenting with acute angle closure. Well, there's been a number of prospective studies and also RCTs versus iridotomy. And essentially, lensectomy comes out on top. There may be persistent angle closure and pressure spikes even after iridotomy. And with lensectomy, there's lower pressure, less medication, and higher success rate doing Phaco versus iridotomy. There's less need for secondary surgeries after Phaco, and less complications in endothelial cell loss with Phaco versus LPI. Now, what about chronic angle closure? So your patient has chronic angle closure with cataract and a history of an LPI. So they had an LPI already. Now, we can differentiate whether the patient's controlled on medications in the office or uncontrolled on pressures on medications in the office. Now, for medically controlled or uncontrolled glaucoma or angle closure with cataract, there's numerous studies out there. Pressures can be reduced from 20 to 56%, and most have a very significant pressure drop, success rate of up to 70-90%. Many are off the medications entirely, and it's found there's less fluctuations and peaks, and it often can be quote-unquote curative. We must also remember that we often measure pressures in the office. We don't realize often these patients can have quite volatile pressure fluctuations. This is the patient whose pressures were 14 to 18 in the office on 2 medications with quote-unquote controlled primary angle closure. But after lensectomy, the IOP significantly were more controlled on home tonometry, reducing peak and reducing fluctuations. Now, Clement Tam and the group from Hong Kong has published a lot in this area. 2 RCTs, Phaco versus combined Phaco traps. So now we're comparing versus Phaco trap here. In medically controlled or medically uncontrolled patients with chronic angle closure. For those that are controlled, it's the same pressure and rate of progression with Phaco versus Phaco trap, but less complications with Phaco. In patients who had uncontrolled glaucoma on medications, the pressure was lower with Phaco trap, but there were less complications and progression with Phaco. However, 16% of patients still have to undergo trabeculectomy after Phaco. Now, what about patients who have chronic angle closure without a cataract and a history of an LPI, uncontrolled on medications? Well, this brings the questions up. What about clear lensectomy? Who is this for? Differentiating versus PACS versus PAC versus PACG. Is this primary or secondary therapy? Is the patient controlled, uncontrolled? Are we looking at clear lensectomy as an alternative to LPI or after an LPI? And is it an effective strategy as an alternative to trabeculectomy? Previous studies have looked at clear lensectomy in primary angle closure. This particular study for Tanusdad and others looked at patients with elevated pressures who had an LPI and were on medications. In this group here, pressures were reduced significantly with a significant increase in trabecular iris area, and overall an 86% success rate. And so in this study, conclusion was that lens extraction performed by an experienced surgeon in eyes with PAC that have preoperative pressure that is more than 25 for at least 8 weeks despite LPI and ocular hypertensive medications. Now, some of us will proceed even earlier than this, but this was a study that was published in 2015. Looking at Phaco versus trabeculectomy in medically uncontrolled chronic angle closure glaucoma without a cataract. So we talked about these 2 studies of with cataract before. This is now looking at Phaco versus trabeculectomy. Similar pressure reductions were found with Phaco versus trab. The trab-treated eyes did require less medication. 50% of eyes in Phaco group required medications versus 20% in trab, but there were significantly more surgical complications in trab group, particularly many who developed cataract, 1/3, but 1/5 of patients with Phaco eventually required trabeculectomy. So what about patients now? Let's switch around a bit more and talk about even earlier. Patient who has chronic angle closure without a cataract or LPI. They may be primary angle closure with elevated pressure with or without medications, or primary angle closure glaucoma with or without medications. Well, this basically defines a population of the EAGLE study, a well-designed study comparing early lensectomy versus LPI in an RCT. It's important to remember these patients were not cataract patients, did not have advanced glaucoma. They were randomized to LPI versus clear lensectomy, and there were numerous outcome measures including patient-reported outcomes, IOP, and cost effectiveness. Essentially, lensectomy came out on top in terms of IOP, in terms of the health quality measurements and quality of life, and also with regards to cost effectiveness. Interestingly enough, more surgery was required in patients who had an LPI versus lensectomy. Now let's look at the results here. IOP reduction, you can see, somewhat similar but more favorable to Phaco. Medications significantly lower in the Phaco group. 61% of patients were medication-free versus 21%. And many less patients required surgery when had Phaco versus iridotomies. In the patients who had iridotomies, a number of patients required further surgery, which included Phaco, trabeculectomy, Ahmed valve, and others. Now, this follow-up study looked at the refractive outcomes and found the spherical equivalent significantly improved with no change in corrected distance visual acuity. However, the predictability of refractive targeting is not as great in these smaller eyes. So the study found superiority of clear lensectomy on patient-reported and clinical results of Phaco versus Iridotomy. There was minimal safety issues, and this was consistent with previous published studies, and therefore lensectomy has been advocated as first-line therapy for primary angle closure with elevated pressure and primary angle closure glaucoma. Now, this is one good quality study. There are some limitations, of course, as well, and there may be lack of generalization. This patient's group was primarily Asian. Lensectomy can be effective, as we mentioned. However, there are numerous important risks to remember that can occur with these patients and with these eyes. Malignant glaucoma can occur if uveal effusions and many other issues that are listed here. The endothelium can be at risk, operating closer to endothelium with patients who already have diseased endothelium. It's important to remember in these small eyes we have to maintain and create space in the anterior chamber and prevent shallowing of the AC. This can be achieved with IV mannitol, a super viscous cohesive viscoelastic agent like Helon 5, and we'll talk about this, the occasional use of a pars plana vitreous tap to deepen the anterior chamber. We like using dispersives and super viscous cohesive agents to protect the cornea and create space. Along with this, it's important to maintain space. Do not allow the AC to shallow in these very small eyes. The re-injection of viscoelastic or BSS can maintain the AC throughout the case without any chamber shallowing, which can cause choroidal expansion or effusions. Now, when we look at results of Phaco in these smaller eyes, we can see as the axial length gets smaller and smaller, the risks of complications go up and up, from 4 to 21 times increased risk of complications. One of the most feared complications is malignant glaucoma, which can occur intraoperatively or after surgery, which typically presents as AC shallowing as a result of choroidal expansion, pushing vitreous forward, reducing its conductivity, and that, along with a small lens iris channel, results in a shallowing of the chamber. Now, the definitive therapy in our experience and many others has been to create a unicameral eye. This doesn't require a large vitrectomy, but requires an iridozonular hyaloidotomy, cutting the iris, peripheral capsule and zonules in the anterior hyaloid and peripheral vitreous to create a communication between the posterior segment of the eye and the anterior segment of the eye. This is an example of a post-op patient who had malignant glaucoma after Phaco, had a laser iridozonular hyaloidotomy, resulting in deepening of the AC and the angle. Now, these patients don't always present with elevated pressure after surgery, but a shallowing of the AC. It's important to look for malignant glaucoma in these susceptible eyes. Now, in these nanophthalmic eyes, there are numerous other complications that have been described in the posterior segment: choroidal effusions, choroidal thickening, and shallowing of the AC, macular and choroidal folds, amongst other things. An RCT compared the use of prophylactic sclerostomy in patients with nanophthalmus and found less post-op effusions in eyes that had sclerostomy performed versus those that didn't. And so in certain eyes, and I'll give you my opinion later, I think it's useful to create a sclerostomy here, typically in one quadrant or even two quadrants if there's a presence of an effusion. We really like looking at imaging like B scans and UBMs and other types of imaging to evaluate preoperatively for the presence of supraciliary fluid or expansion of the choroid. In my experience, we typically look at these two entities, uveal effusion and malignant glaucoma, with serious concern and try to address them. We really try to avoid bleb surgery because this can certainly aggravate these conditions and make it very difficult postoperatively. And again, Phaco can be quite effective. Space creation is very important and maintenance is very critical. We try to avoid making a pars plana tap because this can often lead to insertion of trocars through retina. The retina insertion in normal eyes can be 6 millimeters back from the limbus, but in these small eyes can be even 2.5 millimeters. So you have to enter very anteriorly at risk of hitting the lens in these eyes, and we use UBM to evaluate this. So I really like to avoid making pars plana incisions in these small eyes. Now, for eyes less than 20 millimeters and or history of malignant glaucoma in the fellow eye, I like to do a prophylactic iridozonular hyaloidectomy, typically via an anterior approach with my vitreous cutter, cutting the iris, cutting the peripheral zonules and capsule in the anterior hyaloid end of the case. And if eyes are less than 18 millimeters, I routinely perform single prophylactic sclerostomy to prevent postoperative uveal effusion. Now let's move on to talk about, you've done a phaco, but the pressure doesn't lower. Why is that the case? Well, we often see in these studies that these patients require medications after, or 20% require trabeculectomy. Now, why is that? Well, there can be closed mechanisms. There can be residual PAS or persistent angle closure, or the angle is open, but the trabecular meshwork is dysfunctional. Now, what about if the angle is still closed? Well, this could be because there's still synechia present and we didn't release it during surgery, which I'm a big advocate for. This could be because of persistent mechanisms of angle closure from Plateau iris. Lensectomy doesn't always remove the Plateau component, and the angle may still be closed because of this, or the patient may have malignant glaucoma. When the synechial angle closure, it's imperative, in my opinion, to perform gonioscopy intraoperatively and release the synechia. We published an editorial recently summarizing the data. It's a bit mixed out there, but we believe that there's at least 4 clock hours or more, we should release the synechia with gonisynechial lysis. This can be performed again with cataract surgery effectively using different mechanisms and different treatment tools like micrograspers, using surgical intraoperative gonio lenses like this that don't require tilting of the microscope, or using direct view lenses that can evaluate 360 degrees of the angle without tilting of the microscope. Postoperatively, remember, it may take a while for the trabecular meshwork to regain function, and the patient may require medications for the first few months while this is happening. Pilocarpy may be helpful to prevent synechia formation as well. Now, what if the angle is still closed, not because of synechia, but because of a Plateau configuration or syndrome like this? This can happen even after lensectomy. And it's been shown even after lensectomy, sometimes the angles don't open enough. Here's an example of on the left where the phaco has nicely opened the angle, but on the right it has not. Why? These patients have a high iris insertion because of an anterior positioned large ciliary body, as you can see here. And this results in persistent angle closure. Now, this can be treated by different methods. Of course, the use of argon laser peripheral iridoplasty may be used on the iris postoperatively or preoperatively. But also we can use the endocyclophotocoagulation to rotate the ciliary processes posteriorly. We do this by shrinking the ciliary process, as we'll show here, using the endoscopic probe. Look at how high these ciliary processes are that can result in persistent angle closure. We're basically lasering the tails of these processes to shrink them. We like using imaging to evaluate these eyes to determine which eyes may be helped by using ECP, or I call it endocycloplasty, to shrink these processes back versus just doing lensectomy alone. Look how high these processes are. They're so tall. We're going to laser these to shrink these back. This is more a mechanical effect. We're not necessarily aiming to reduce aqueous production here, as opposed to primarily shrinking these processes back. And we can see on UBM examples of the flattening of the processes with the opening of the angle in the area that's treated, but the remaining angle that's not treated may still show persistent angle closure. We usually treat about 180 degrees or so to make sure we have at least that much of the angle open. Look at the big difference in this eye, treated versus untreated areas of the ciliary body being so high. Again, another example here on anterior OCT. Now, can we predict those angles that may not open versus with phaco versus those that may? I like to look at a ratio of the lens rise to anterior chamber ratio. How much of the AC above the scleral spur is occupied by the lens? Here I show an example of the AC in red. This is how we look at by the spur, not by necessarily by the actual lens itself. And versus the lens rise, which is again a line drawn from the spur above that. Here's an example where the lens is occupying a third or more. In this case, it's almost a half of the anterior chamber from the scleral spur line. This example here, the lens is primarily the problem here. This is high lens rise. Removing the lens will help here. Here is fairly low though. That's like maybe a fifth of the anterior chamber space above the spur. This is an example where removing the lens is probably not going to be enough because the issue is primarily a high iris insertion or plateau. Another example here, we can see the angle being closed by large ciliary processes. Now, finally, if the phaco doesn't lower the pressure and the angle is still open, this patient may have a combined mechanism of glaucoma. Now, why doesn't lens removal in these cases, and if the angle is open up, why is it not normalizing the pressure? This is a very interesting paper looking at histopathology of TM in angle closure. Essentially what this found basically is persistent angle closure, even without synechia, can lead to physical impairment and dysfunction of trabecular meshwork. So even when the angle is open because of chronic appositional closure, but even worse at the synechia, even if you release the synechia, the ingrowth and the damage to the trabecular meshwork may be persistent even when you open it up. And this tells us it's important to address this early. It's important to address angle closure early to prevent these chronic secondary trabecular meshwork and even beyond in the canal and the collector system that may occur. It's an argument for early intervention. It's an argument also to consider doing adjunctive angle procedures, like mixed procedures, to address the trabecular meshwork because it may not be enough even opening the angle up. And there's various ways to do this with trabecular meshwork procedures, whether they're cutting, stenting, or dilating. We see some RCTs that will be started up comparing the use of phaco goniotomy versus phaco trab. It should be interesting to see whether this can further lower pressure and reduce the need to do secondary surgeries. So to summarize, medically uncontrolled PAC or PACG with a patent LPI or progressive PAS or glaucoma progression is a consideration for clear lensectomy. Based on the EAGLE study also, it may be considered first line even in patients without a cataract who have PAC with a pressure over 30 or PACG in those that are greater than 50. What about for advanced uncontrolled PACG? Well, phaco trab may be the optimal option, but I still consider doing phaco alone with a mixed procedure to avoid the complications of trabeculectomy. And what about patients who have PAC or PACG with persistent iridotrabecular apposition or synechia? Even if controlling medication, there's an argument those patients may benefit from having clear lensectomy for reasons I mentioned. I should mention that, however, as at this time, there is no role for a clear lensectomy in PACS. Pressures are controlled, no medications, no synechia, no glaucoma. I don't typically do lensectomy. Again, I'd really prefer not to do a phaco trab or a bleb procedure in these eyes. I think they're more complicated and there's a higher risk for failure. I typically avoid blebs in these eyes for the high risk that we know. So don't make a hole. Deal with the underlying mechanism of trabecular meshwork obstruction, and the sooner the better. I do believe it's helpful to look at mechanisms at play, whether it's high lens rise or plateau or pupil block, deal with synechia, consider the other mechanisms that may be helped by relieving trabecular meshwork dysfunction, and prevent malignant glaucoma or uveicular fusions as necessary. Imaging has definitely helped us as well. Hope the talk has given you some guidance on lensectomy, particularly clear lensectomy and primary angle closure in PACG. I think it can be a very definitive susion, but there are, of course, risks in these patients, and it needs to be performed by an experienced surgeon who's comfortable dealing with small eyes and the complications that may occur after surgery. Thank you so kindly for listening to this talk, and again, I hope to see many of you in person in the near future. Thank you.